The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to the November 25th Safe Income webinar. This is Deanna Mitchell again with Leading Age Michigan. Cases are continuing to rise overall, and especially in Michigan, although we are kind of happy to report that the daily incline here has not been directly up every single day during the past week. There has been some up and down movement, which is somewhat an improvement, although overall the trends continue to move upward. And community transmission is still high across the state. It's been another hard week for members and providers, but we sincerely hope that everyone is able to have a safe and happy Thanksgiving during this challenging time. And we also want to remind everyone that our next webinar is for Wednesday, December 2nd. There is no Safe Income webinar for this Friday. Do look for your emails, though, just in case there are any updates that come out that are really important. We will be sending those forward via the listserv. So today, we do have quite a few updates for you. The department has put out a lot of detailed guidance in the past couple days, and we'll be reviewing that with a focus on the testing requirements for nursing homes, AFCs, and HFAs, along with some other general updates, especially from the CDC. We're going to review some recent member questions as well. And to start our morning off, we're going to turn the presentation over to Dalton, our Director for Public Policy. He has a very brief announcement and a review of our important upcoming dates list.
Good morning, everyone. So for those of you who have not heard, Director Robert Gordon, the head of MDHHS, has been tapped to be one of the two leaders for President-elect Joe Biden's transition team for the U.S. Department of Health and Human Services. Director Gordon came to us from kind of the national level. He served in the Obama administration. He worked in the Office of Management and Budget for 4 years, and he has 6 months as acting secretary in the U.S. Department of Education. So we do expect him to be given a larger role after the transition, but nothing formal has been announced. But just for those of you who haven't heard, it is likely Director Gordon will be moving on, or moving back to, I should say, the national stage. Moving on to our important date slide, I'm going to highlight the same ones as last week. So if you were on the call last week, you will know that the deadline for submitting in-person visitation aids, CMP applications is the first, and also, as I'm sure you're all aware, the CRC and CR or CRF application deadline is December 1st. So please get your application submitted if you'd like to take advantage of either of those programs.
Thanks, Dalton. We're going to move directly this morning to our Michigan update before we go to any questions. And this morning, we're going to start with our standard 7-day rolling average of daily new Michigan cases. And you can see that the recent peak really far exceeds and continues to grow compared to our early pandemic surge. The rate of incline, though, is decreasing, as I said before, but overall, the daily number of cases continues to rise. The same is pretty much true in terms of COVID-related deaths. The 7-day rolling average has always been a bit more unstable than the daily case rate, but we believe that's partly because the reporting is more often done in batches for deaths. So you'll always have some highs and lows, some ups and downs. But again, in general, deaths are also rising. The recent instability in caseload, though, which is in effect a good thing because it is not a steady incline, it can be seen in the state test positivity rates. The MDHHS data on this always has a bit of a lag, but you can see that since about November 12th, the data is no longer on a steep incline, and this may be a sign that additional efforts on containment may actually be working And maybe we're rounding a curve. However, it's probably too early to really say that. Here is our updated graph on weekly SNF case reporting as of November 23, Monday. Remember that this reporting is only updated weekly. And this is the only case for SNFs, that is, where reporting has been pretty much 99 to 100% since the department started publishing these numbers. So these numbers are going to be more accurate than for AFCs or HFAs. You can see that there does continue to be an incline in the number of new cases, but it's at a slower rate of growth. So as of Monday, there were 792 new nursing home cases. That's still a considerable amount of transmission going on there. Again, when looking at the HFA and AFC graphics, the story's a bit different because few were actually reporting when MDHHS started publishing the data. So right now, excuse me, for HFAs, only 79% are reporting at this point. So this steep incline in the middle of the graph is more likely due to increased reporting than increased caseload. And you'll see that there was a very slight decline to 182 new weekly cases as of Monday. For AFCs, the same is also true. We are up to 75% of AFCs now reporting. And we again had that steep incline in the middle of the graph, which is really due to, I think, more reporting than it is actually case increases. And we've seen a decrease in the number of new cases to 64 as of Monday. The Michigan MySafe Start map continues to be completely dark purple, and the county risk levels are still at E throughout the state. One good sign is that as of 11/20 data, remembering that the data goes up and down a little bit, the 7-day average of new cases had actually gone down from 4,900 plus to 4,660 plus this past week, as of the 20th, remember though. This data is a little old. I'm actually unsure how that's possible because on the same page, the positivity rate and the number of tests done are higher, but these are the numbers directly off the MySafe Start website, and our numbers are showing some up and down movement as well. So it could be that we are doing a little bit better, but we'll have to wait and see. So we're going to move on and get into our resources and guidance section, and we will take some questions shortly. So today we're going to start with a brief update about NHSN reporting because we want to also talk about reporting for Michigan in a moment, and they are topics that we need to talk about together. SNF providers will note that there are new definitions and reporting requirements, and we talked about those last week. They went into effect on Monday. The CDC and HSN people have held one training so far, but at this point there are no slides or recordings available from that session. However, they do plan to schedule more informational trainings, but we could not find where they are scheduled at as of yet. But that leads us into a discussion about MDHHS and the reporting requirements both for SNFs and AFCs and HFAs. The department put out a press release and a notice yesterday about this. Weekly reporting, as we know, is scheduled for Wednesday mornings, and all required provider types should be reporting today. They sent out several notices about this, and I'm not sure if they are concerned about the holiday or not getting their data, but they've sent out 2 or 3 notices now reminding everyone that they need to report today. So at the same time, they also issued a notice that they have aligned the content in EM resource for SNFs with the new definitions and requirements for NHSN reporting. But they're not sure if the platform is actually ready to transmit all of the data accurately at this point. So they're still working through some of the technical issues. So for right now, at least, SNFs are asked to report in both NHSN and EM resource, but the content in EM resource, according to the department, has been aligned with the new NHSN requirements. They also note that HFAs and AFCs also have weekly reporting that's due today. And excuse me, as we noted earlier, not all entities are yet reporting. And they are encouraging everyone who has not yet registered to do so today. They can do that until noon today. And if they do register today, they can start reporting on December 2, which is next Wednesday. This is a brief update on the current care and recovery centers that have been approved in Michigan. You can see that they're still not distributed very well across the state. We do want to acknowledge that St. Anne's Home has taken on this mission, as you can see on the slide. So currently we have 6 centers and only one remaining regional hub that's in transition. We do know that there are several applications still going through the process, however. Yesterday, the department started reporting lab turnaround times. The link for that site for members who might want to look at that is at the top of the slide. You can see that the 2-week average turnaround time for commercial labs is still over 3 days. Hospital and public health labs are hovering around 2. But if you go down the list a bit, you'll see that there's still a lot of variation among those private labs. And the list that's actually on the website is really quite long. So I've only copied the first portion here. The rest, there's quite a few labs. So this is a resource available to you if you're looking for a good lab to do your testing. The department on Monday released a guidance on safe holiday practices, and they announced a new program that partners with an electronic communications company called Get Set Up. And this program is intended to help persons, especially vulnerable seniors, deal with separation from family and others during the holidays. So they've designed some specific programs that help with socializing in and of themselves, and they also train seniors to use technology to help them connect with family and friends. There are program dates and times. They are noted here, and the registration information is at the bottom of the page. So this might be something for some of your residents to use if appropriate for them. Additionally, the department issued guidance for safe holiday practices for vulnerable populations. They specifically focus on the requirement that the visitation guidance from October 21 is still in effect, even though all counties are now at an E risk level. There isn't a whole lot of visiting going on except for those exception areas. They do stress that for the holidays, and actually for any time, the residents at this point should be discouraged from leaving the facility. But of course, you cannot stop them from leaving if they choose to. But they do suggest that you remind them that there are continued social distancing rules in effect, and that the November 18 guidance that limits indoor gatherings and in particular holiday gatherings with the idea of pods, etc., that's all still active and in place for them as well if they wish to leave the facility and visit their families. So here is a list of the safeguards that facilities can use to inform their residents about what they should be concerned about if they go out. There's nothing really surprising here that you wouldn't already expect, but it is a comprehensive list that you might want to review with residents who might be going out. The department also suggests that facilities review the CMS Thanksgiving guidance for nursing homes. And last but not least, at the bottom, the link for the MDHH press release for this whole piece is on the slide. So before we move on, let's see if there are any questions. Blake?
All right, thank you very much, Deanna. We just wanted to give everyone an update on our Serving with Grace event happening on December 9th. We will still be holding it on the December 9th, but to best accommodate our members, their staff, and then maybe any family members who would like to join and watch someone win an award, we have decided to change up the timing of the event a little bit, so I will give you a little bit of explanation on that. But before that, I do just want to say that each year, Leading Age Michigan honors individuals and groups who embody excellence in leadership, care, and service innovation, and who have made outstanding contributions to their communities in the field of long-term care. During this event, we also would like to celebrate our members, all of their staff, and the entire long-term care industry during these challenging times. So how we have decided to switch it up, it will still be on Wednesday, December 9th. It will be a free live streaming event on the Leading Age Michigan Facebook page, but we will be at 1 p.m. until about 2 p.m. We will be having a keynote presentation during that time, and then so we can have everyone and all of their family members join for the Member Awards Gala. We will be reconvening at 7 p.m. So hopefully that makes it easier for all of our award winners to join their family members and the staff, because we would like to celebrate with everyone. So as I said, it will be a virtually acknowledged event for our award winners, and we'll be joined by two of Michigan's greatest resources, Monica Levin and Tim Cusack. We are excited to be able to acknowledge our many award winners and celebrate one another, as we will do our best during these very challenging times. Leading Age Michigan would also like to thank our dedicated business partners who continue to support our members, their staff, and the association in everything we do. So for that, we would like to thank Omnicare and our contact over there, Matthew Garlick. We'd like to thank Ziegler and Tom Myers. We'd like to thank Andy McLeod over at GMB, Sheila Ralston at Creative Dining, and Kim Murphy and Carrie Hensel over at Therapy Management. We will have a RSVP sent out shortly to everyone, so you should be able to register, and that way we can get the link over to you and you can join us on December 9th, hopefully at 1 p.m. and 7 p.m. So together with our sponsors, we know by working together and offering support to one another, we can overcome anything. So come and please celebrate one another with us on December 9th. Looks like I just have one question right now. It says, sorry to say, but I do not see that EMR has aligned with NHSN.
Well, that might be true. I don't know. I'm only responding to the guidance that the department put out. If you don't think that they are aligned, we will send that note to the department and see what's up. But we received 2 or 3 notices saying that they have aligned the content, but not necessarily the pathway. So we'll follow up on that.
All right. Looks like that was the only question, so we can go ahead and move on.
Okay, so next, we want to take a moment to review some of the recent questions and issues that have come up. The first is an important one. We've not discussed it in these webinars much lately, I don't believe. I do remember that we had conversations earlier, and this is really about end-of-life visits to COVID-positive persons. But I think that we talked about this mostly when there was no allowed visitation at all. And we were talking about the need for these persons to see their family and friends at end of life. We do know that, or at least we believe that there are some members who are allowing visitation to COVID-positive persons at end of life. And the guidance does pretty much say that end of life visits, excuse me, have almost no restrictions. And we also heard that a medical director from one of the county public health departments believes that the guidance allows it. However, if you review the October 21 guidance, you'll see that section 2C, which has a list of requirements for facilities, and those provisions are without exception Number 19 precludes any visits to COVID positive persons or persons under observation even. And I believe at this point that that is what the department intended. So we have started a conversation well over a week ago with the department about this, and they did get back to us. Since we believe that these visits are essential, if appropriate safeguards are in place, but they have not responded with a real answer, only that they are considering it. And that confirms to me that there was intention in the guidance to completely prohibit these visits. So it looks to us that right now they're kind of struggling internally about all of the social implications of that prohibition. And we're still waiting for final guidance. We will follow up with them if we don't hear from them soon. It's been several days actually since they responded that they're thinking about the impact that these prohibitions are making on our consumers and members. So another question is about the BINAX form. And we're going to talk about that a little bit more when we get into the testing updates. But there is this BINAX form. So originally when the department started talking about HFAs and AFCs, they put out a link for reporting for them. And then later in a training, they introduced this BINAX form. So apparently the National Guard told a member that all tests have to be noted on this additional form. And that's not true. We're going to talk about it again a little bit later, but this form that the BINAX reporting form, and there's a link later and in the testing guidance, this form is only for AFCs and HFAs. It does not have to be completed for nursing homes. And it's actually only for BINAX tests as well. So we'll get that into those details a little bit later, but I wanted to confirm we have gotten this question from at least 2 members. So this next question took a while for us to get a response to, but I do have the CDC response and the associated guidance that addresses this. So we had a member ask us if staff are being tested out of doors and a staff tests positive, if the staff has had no other contact with the facility for 48 hours, is that an outbreak? And the answer is no. And the concern was the fact that the staff conducting the test had some interaction, obviously, to get the test. But if that staff used all of the appropriate precautions, then the CDC does not consider that an exposure, and the risk is low, and thus that's not an outbreak. And that's really a good thing, because if every time you have staff testing positive, then you have, and that's an outbreak, that'll just throw everybody into a crazy area. Scheduling tests twice a week. We have no good answer to this. The CMS guidance, when you get to a red risk level, we all know requires twice weekly testing. There is no further detailed information about what twice weekly means. So we reached out to Laura, and they referred us back to MDHHS and told us that MDHHS makes all the testing guidance. And so I did have to remind them back that this is a CMS rule, and they never responded again to that. So right now, in terms of scheduling around the holidays, we believe that there's nothing in this guidance that would preclude you from going down to a 2-day interval if you needed to, as long as you have 2 testing dates within each calendar week and you are in a red risk CMS category. Do staff have to be tested weekly or twice weekly when they work infrequently? So if someone's only working 1 weekend a month, are they required, if they're in a red area, to come in twice weekly? This is a gray area still. During the leading age presentation during their conference by Evan Schulman, who is the director from CMS, he stated that he understood that testing twice per week for someone who may work very infrequently doesn't work, and that such persons should be tested on return, and that this would be considered the same as someone returning from vacation. But that's not written in guidance anywhere. It was only during the presentation. And MDHHS noted that persons who are working infrequently, still need to be tested at least weekly. So there does seem to be some conflict there. We think there should be some leeway, but the idea has not really been tested, and so we've reached out to the department to see what they're going to say. Lots of questions about nurse aid recertifications lately. Nurse aid certifications were never exempted during the pandemic. So they have to meet all the normal requirements, and if by chance their certifications lapse, they will have to retake the test. HUD payments. HUD has issued another round of supplemental funds for HUD-assisted multifamily housing providers, and these funds are directly related to COVID issues, though. There is a filing deadline of December 11 for expenses incurred through November 30th. And if you didn't happen to apply for any funds earlier, you can also apply for funds related to COVID expenses that you've incurred earlier in the pandemic as well. So detailed information about applying is at the link at the bottom of the page. And of course, Leading Age National has resources available to help you as well. So the CDC has updated two major guidance over the past week. Optimization for use of face masks and also for N95 masks. They wanted to remind everyone that there is a continuum of options for optimizing PPE. There's conventional, which is normal use, contingent, and crisis strategies. And the expectation is that these strategies must be considered sequentially. You shouldn't just jump to crisis strategies when supplies are low. You should use the interim activities and changes first. Also, there's really no defined criteria for what contingent versus crisis means, and each facility would have to look at their supply issues and determine when to move to crisis mode. So all of the strategies that they talk about are based on the need for facilities to fully understand the supply chain, what their options are in working with state entities, and that there are other controls to protect residents and help in the safe use of PPE, such as cohorting, limiting interactions. Those are all part of the response necessary to optimize use of PPE. And of course, most importantly, that all staff must understand how to don and doff PPE safely and effectively. The November 23 update clarified the use of face masks for source control and the use of face masks as PPE. When used for PPE under normal circumstances, so that's not where we are right now, but under normal circumstances, face masks should be removed and discarded after each encounter if they're used as personal protection equipment. But if they're used for source control, even under normal circumstances, you can use them for a long period of time. And all the strategies on this page are for normal use. Apparently, they want to know the difference between a surgical face mask and those are safer for exposures than those that have been used in the past for normal isolation purposes. So they prefer surgical face masks when possible, and they're certainly preferred for high transmission procedures. When looking at face masks in terms of contingency strategies, they suggest that if they are in short supply, that you secure face masks and not have them out for public use. In other words, not have them freely available for everyone to just grab, and that you should have them in a protected place. You can extend the use of face masks as PPE when caring for residents if you have to. Remember that in normal situations, as we just said, you discard them after each encounter. But when needed, you can extend the use for care. with several different patients, as long as all those patients have similar conditions. In other words, even taking out of the discussion the idea that you wouldn't move from a COVID dedicated unit and care for non-COVID residents, you also shouldn't be caring for someone who might have influenza and then move to a non-influenza person with the same face mask. So you have to make sure that your patients have similar conditions before you extend the use of the face mask. So here are some additional safeguards for contingency strategies. Face masks, remember, are considered a transmission risk in and of themselves, so that when you're wearing them and you're exposed to the virus or other contaminants, the face mask actually can be contaminated quite easily. So anytime a person touches that face mask, and the surveyors are going to be looking closely for that, hand washing has to occur. We know that's hard to do. We know the face masks move, but the expectation is that hand washing should occur whenever they're touched. They should only be removed when outside of a resident care area. And if necessary, and this is a later form of a contingency strategy, you would want to reserve those surgical face masks for healthcare personnel and for persons who might be in at least droplet precautions. And you can use face masks for other residents for source control, cloth masks for other residents for source control, etc., if the supplies become very, very tight. In crisis situations, you can use face masks that have actually expired beyond the time that the manufacturer recommends. And you can not only extend the use of a face mask, but you can reuse it if absolutely necessary, which means that you can do both. You can use them for more than one resident, and then you can take it off and put it back on later, perhaps after a break, after lunch, coming back, if cared for properly. At any time, any face mask that is damaged or soiled must be discarded. But if you do that, if you do reuse it, you have to take it off, carefully fold it in so that the outside is folded inward. It should be stored in a clean bag or some sort of container. And of course, you have to wash your hands. And lastly, if you don't have enough face masks to go around, you can prioritize their use for certain high-risk procedures. That would be for potentially infectious patients. If you don't have enough N95s around, obviously you should use N95s for COVID positive or COVID suspected persons when you can. But if both face masks and respirators are unavailable, the CDC recommends you use cloth masks and a face shield. So the CDC also updated its guidance on N95 use. These, of course, are pretty much intended to be used once and then discarded originally under normal use. They are generally used for airborne infections, and during the pandemic in areas with medium or high transmission rates, they are intended for care of COVID positive and suspected residents. And indeed, if there's a lot of high transmission rate, they are expected to be used for everyone. Although they do think COVID is mostly conveyed through droplets, there are studies that have implied an airborne element. And of course, the virus is so highly contagious that N95s are preferred for use, especially throughout Michigan now, since we are in such a high transmission stage. The guidance also reminds facilities that are additional safeguards that work to enhance the use of N95s and other PPE when you have to extend their use. And those are things that we discussed earlier since about cohorting, limiting face-to-face contacts with residents to those that are essential, etc. So for contingencies, you can do similar things for within 95s as we discussed with face masks. You can use them beyond the expiration date. You can use the same one for a group of residents as long as they have the same infectious disease or they have no infectious disease and similar conditions. You have to be careful that if you are extending their use that they continue to fit. They should be discarded after extending the use through working with several residents, but if absolutely necessary, you can also reuse them later. Face shields help in protecting you from the virus, but also they help protect contaminating the respirator. So if you use a face shield with a respirator, which we're all required to use pretty much at this point anyway, although some people use goggles, that protects the respirator from becoming contaminated during aerosol generating procedures as well. I'm sorry, go back, Blake. So in crisis, you can consider using respirators from other countries, and we know that a lot of our members have KN95s from China. This includes the emergency use of KN95s that have been approved by the FDA. So again, this is a reminder that you can use those. I think that we're all in the stage where we're going to have to do that, but they do have to be approved by the FDA, and all KN95s are not. You must be careful if you are reusing a respirator because taking it off and putting it back on, if you're caring for COVID positive or COVID suspect patients, in and of itself could transmit the virus. The outside is always considered contaminated. The CDC now recommends, and this is one of the new pieces, that if the manufacturer does not include information on the maximum number of times you can take this respirator off, put it back on, that 5 times is the limit. And of course, these should never be shared among staff, but if absolutely necessary, and as a last resort in crisis times, you can decontaminate them, and the CDC does have guidance about decontaminating respirators. Okay, now the department put out an updated guidance for the testing FAQs, and it's something like 15 pages long now. And we're going to review them shortly, but in that document, they referred to the antigen testing guidance as well. And because there are some specific things in that guidance that we think that it's important to review, we're going to go through that first a bit. Although that guidance itself is not new, there are some important elements that we should probably talk about. So at this point, everyone should know that it does not take a physician to order the test, and a wide range of professionals can do that. And anyone can also be trained to conduct the test, but everyone should ensure that they have documentation about how they wto and how they're competent, since the risk of infection is so high. They require persons who are conducting the test to go through 2 training programs, and both of those are listed here. So make sure that whoever is conducting the test, no matter how they're trained, the department is requiring that these 2 videos be reviewed by people conducting the test. Remember that CLIA waivers are required for any point of care test, and the application can be submitted directly to the state. Remember that you must include the types of tests that you want to conduct. You have to list them off. And you should be reviewing information about the appropriate use of these antigen tests, and most importantly, how to interpret them. The guidance includes a flow chart that talks about how to confirm in certain situations. And that flow chart is in alignment with the one from the CDC that we have talked about numerous times before. So there's nothing new in that respect. All SNF reporting can be done through EM Resource in terms of the point of care test reporting among the other reporting that's required there. HFAs and AFCs must use the online Binax results reporting form for only Binax tests. And there is a number in the guidance for anyone who has any questions just about the Binax test. The guidance goes on to talk about appropriate disposal of test cards. Those can be disposed in standard trash bags as long as there is no blood or human tissue. In which case, if there is that, you have to discard them as medical waste. And if you have questions about the medical waste issues only, there is a link to an email address about how to safely dispose of these supplies. So that's the background for the antigen test requirements. Moving on to the updated FAQs, there is, of course, the same email address for any questions. Facilities at this point should have received their antigen tests from the state. And if not, members should contact the noted email address here. If you're attempting to get supplies and you have not gotten them, you will not be cited as long as you are attempting to comply to the point possible in terms of testing. You can choose to have a lab do all of your testing, and MDHHS will reimburse as they did before under the regular rules. The reimbursement guidance, as a reminder, is at the link noted on the slide. And one of the reminders is that facilities should reorder when they have no less than 2 weeks of supplies left. We have heard a rumor, just one, that the state is running low on supplies. I don't know if that's true or not. We'll continue to look at that. But for right now, the department wants you to reorder when you have at least 2 weeks of supplies left. There was a whole section in the updated guidance about AFCs and HFA. I'm sorry, just AFCs. AFCs, again, have to comply with these orders if they're licensed for 13 or more beds. It doesn't matter how many residents you actually have. And if you have a facility license for 13 or more, if you have a license, several licenses for 13 or more, you have to report for each of those. The department is hoping to cover the costs of the CLIA waiver, at least for AFCs. They're currently working on a process and a guidance for that. There's a reminder that you cannot start testing without a CLIA waiver. And if you do not currently have a CLIA waiver, you should contact the department. They are working to expedite these applications that are sent directly to them through the email address that's, again, noted here on the slide. Some facilities have the ability to hold a CLIA waiver that covers more than one provider type. This question came up yesterday. There are certain requirements, and there's some confusion about this because when you apply for a CLIA waiver, you only submit your tax ID number. So there's no way for them to know, I don't know, if you hold several licenses under that number. But the guidance says that you have to have a CLIA waiver for each license. So we've asked the department to clarify that somewhat, and we're still waiting for a response. There are informational resources here for on CLIA waivers, and when filling out the application, the department says that AFCs should call themselves assisted living facilities. Again, ensure that you list all the types of tests you intend to conduct under the waiver. When you submit for a CLIA waiver, you will not get a confirmation that the application was received, but you should get an approval in about 14 to 30 days via email. So, reporting. Antigen testing for SNFs is supposed to be reported directly to NHSN And as we said before, and EM resource, SNFs must do both for now. We will check to see if they have aligned the content, but according to them, they had. HFAs and AFCs should use the BINAX reporting form only for the BINAX report. And this was hard for me to understand. You still have to report if you're an HFA or AFC, other types of reporting for antigen tests to local public health. And you're to use the original fillable PDF form that was originally distributed, and that is actually in the guidance. So you have to report in two different ways. If you're using a BINAX test, you use that piece. And if you're using any other kind of antigen test, you have to report to the local public health department. This felt complicated to me, but that is what the department's saying. They also note that all the information that is submitted through the BINAX reporting, it goes to the state and local authorities. So everybody should know everything, more or less. The rest of the guidance, we're going to go through quickly because most of it is not new. This has not changed. Residents have the right to refuse. Remember, never force a resident to take the test, even when the legal representative might approve. But any resident or staff who is symptomatic and declines to be tested must be treated as positive. Staff who are asymptomatic and decline cannot work with residents. And you have to determine on a case-by-case basis whether or not you need to quarantine any residents who decline. And that is a physician determination based on risk and based on what is going on in both the facility and the local community. So that needs to be determined on a case-by-case basis. And you, of course, have to include testing refusal policies in your testing plan. You need to have policies for all of that. And lastly, they remind everyone that the ADA requirements still hold. And if you need to review those, there's a link at the bottom of the slide. Again, this is mostly old information, but we wanted to remind everyone that persons must be tested on admission, whether or not right now you're an AFC, HFA, or a SNF, on admission. Facilities don't have 72 hours to conduct this test. We still get members who are telling us that they're testing within 72 hours of admission, and that is not the requirement. The only reason not to test on admission is if the test was conducted within 3 days before admission. So if you are not testing immediately on admission, you're really taking a risk. And I don't know why, but apparently there's a lot of confusion about this that continues. Another provision that we want to point to is determining whether or not a person with non-respiratory symptoms should be suspected of having COVID. And the department states that that is completely a clinical decision to be made by the physician. The rest of this, there's nothing really new here, so we're not going to review it. It's just here as a reminder if you want to go through it. Also, these are mostly not new, but when thinking about resident contacts, they define resident contact in the guidance. That's not new. And employee exposures. They now guide you directly to the CDC site that talks about what an exposure is. So even though an employee may come up against a COVID positive person, as long as they're doing all of the protective things, that's not considered an exposure. So we think that this is a good time for maybe to review that CDC guidance about that. And this is the issue that came up when we were talking about whether or not you have an outbreak based on the fact that a staff person was positive but only had a contact with the staff conducting the test. That was not an exposure. So I think that this has some good information in it. There's a grid on the CDC site that describes the different types of staff exposures and the relative risk for each. You must continue to work to get all your testing results within 48 hours. And there continues to be an expectation that if you cannot do that, you should be using antigen tests. There's a reminder that there's a staffing assistance program available, but we all know that it's hard to use, and often they do not have staff to assign either. Any employee working in any part of the building who tests positive will trigger the outbreak response. That's a frequent question that we get. If there's a staff person in an office who doesn't have any patient contact, doesn't matter, that will trigger the entire outbreak response. Also, remember to consider all antigen tests that are positive as positive, even when you have a follow-up PCR test that is negative. You are required to continue to isolate that person and treat them as positive. This is the reimbursement section. It's not really changed. The detailed guidance for that is at the link noted on the slide. Again, there have been no changes here, but you can review this if needed. This is a reminder that you must use labs, if you're using labs, that take Medicaid, or MDHHS will not reimburse the lab for costs. And of course, you must pay any of the bills upfront and submit for reimbursement later. Also a reminder not to include any protected information or any individual information, but MDHHS may audit you later. So before closing for today, we're going to go over a few updates for nursing homes only. The first is about provider relief payments for nursing home infection control. If you remember, there are two performance criteria. One is focused on the number of cases in your facility and the caseload rate. And the second is about COVID mortality rates. Apparently, CMS had a hard time using mortality rates, and so they've changed the measure to overall mortality rates. They're saying that processing these payments should now take less time. The second portion of the September payments will go out on November 30. A reminder that providers have 90 days after receipt of the payments to attest, and you have to attest each time you get a payment, so it isn't just a one-time thing. And you have to use these funds for infection control costs under the terms and conditions that have been published, and the link to the terms and the conditions are here as well. And last but certainly not least for today, we've been asked by the Bureau to distribute this link to a survey that gathers information about nursing home capacity. They're asking each facility to just complete one survey, but of course, if you have more than one facility, you need to complete one survey for each. And they ask that the survey be submitted by December 23rd. We just got this guidance. I have not looked at the survey at all, so I'm not sure how complex it is, but they have asked us to forward it to you. Okay, that was a lot of stuff, I know. I kind of apologize for that, but we want to make sure that everybody understands all the nuances. It does seem to me personally that all of the rules are getting deeper and more complicated, so I know it's hard to manage all this information. Any questions?
All right, thank you, Deanna. We do have a couple, so I'll just hop right into those. In IL, if staff are wearing N95 masks, are they required to be fit tested, or is fit testing only in licensed facilities?
We have heard different responses about fit testing. We've heard that some of the surveyors in nursing homes are not actually requiring all the rules for fit testing in some areas. I know that the CDC encourages a respiratory program. The thing about fit testing is that, you know, the respirator doesn't work well unless you have some idea that it is fitted properly on the face. It is so complicated that when I have tried to review all of the guidance for fit testing, there's quantitative and qualitative testing. It's overwhelming, I'll be honest with you. And I've always said that I'm not an expert on this. But I think that the best thing to do here is to contact your local health department. They often have experts on fit testing available, and I think that they can probably tell you best what the requirements should be. I do know that a lot of facilities, while fit testing is encouraged, I don't think are doing it, and some of the survey agencies are not really looking at it either. So it's really kind of a mess, one of the messy rules right now. And again, I would encourage you to go to your local health department and see what they say.
If you have a non-licensed assisted living and you use the Binax, do you have to use the Binax form to record your symptoms?
You're not required to report at all if you're an unlicensed AFC, so no.
Okay. We recently had the National Guard.
Let me go back though.
Sorry.
Let me go back though. But anyone who has a positive test anywhere should be reporting to their local health department. So there's no requirements that you report officially to the state, but any positive test should be reported to your local health department. Okay, go ahead.
Okay. We recently had the National Guard in to provide training on Binax tests. This training was documented. Would this be considered sufficient by the department, or do we still need to have trained staff complete the 2 training videos?
According to the guidance, every staff member who's doing it has to go through those 2 training videos. So I would say unless the training included one or both of those videos, you would still have to do that.
Please clarify testing requirements for PRN staff, such as a therapy fill-in.
Again, assuming that person is an employee of the facility, technically you are supposed to test weekly or biweekly, depending on your CMS requirement. If you're not a red area, you can go back to weekly based on the MDHHS and CMS guidance. If they're only coming in PRN, this is the question that we have into the state. The Evan Schulman presentation stated that you could treat these persons as if they were on vacation and not available, and test them when they return. So a PRN person, I can't imagine you testing them every week or twice a week when you don't even see them for weeks and weeks on end. And so we have that question into the department, who in their guidance said, but every staff person has to be tested weekly. So we want clarification from the state, but the CMS, if this is a nursing home, which I assume it is implying that you can treat this person as kind of like they're on vacation and test them when they return. So I don't have clear guidance from the state, and I have an inference from the feds. So I guess in the interim, the safe thing to do is to try to test them as weekly or biweekly, or not biweekly, but twice a week as needed. But we're hoping to get a little bit of flexibility about that. But I don't have anything confirmed in writing that says that to this point.
Okay, thank you very much. It looks like there is one question left from a Aaron Elias, something along those lines. Aaron, I am just going to actually send that question over to Deanna and just have her email it to you. She just has some links and stuff, so I think it would be better if you could actually look at it and respond to her.
Okay.
So other than that, that takes care of all the questions. So if you do think of anything after this webinar has concluded, as always, feel free to shoot an email over to Dalton, Deanna, or the Safe and Calm at leadingagemi.org, and we'll make sure to get that answered for you as soon as we can. So with that, we would like to thank Deanna and Dalton, and we would also like to thank the 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, just a quick reminder that we will not be holding our webinar this upcoming Friday. So our next Safe and Calm webinar will be Wednesday, December 2nd at 10 a.m. Eastern Standard Time, as always. Other than that, I hope everyone has a great remainder of their Wednesday, has a great Thanksgiving, however you decide to celebrate that. And stay safe and have a great long weekend. Thank you, everyone.
Thank you, everyone. Have a good weekend.
Happy Thanksgiving.